Hello, my name is Ruben Mesa, and I'm the Executive Director of the Atrium Health Wake Forest Baptist Comprehensive Cancer Center. And delighted to be joined by this wonderful panel of experts in myeloproliferative neoplasms for us to take a deep dive in myelofibrosis. So Naveen, we've done the clinical workup, we've done the workup in hematopathology, you have your NGS. What are you recommending to folks in terms of, we now have a myriad of different prognostic scores? Which ones are you telling your fellows that are training from your program, which one to do? And then how do you start to factor that in as you try to come up with your plan for that frontline therapy?
Thanks, Ruben. I think this is a very important question because it has the component of the academic component that we all worked on, and it is actually something I use truly in the clinic. It's also aided by being available online now too. So back in the older days when you're hand calculating, maybe a bit more difficult to do. So quick history on this topic. The prognostic scoring system, so they end in PSS, really started, as you and I well know, with the IPSS in 2008, 09, around that time, pre-JAK inhibitor era. So we all use that, really designed at diagnosis. So that's now been replaced by the subsequent models, the DIPSS, so DIPS plus, each one subsequently adding molecular and cytogenetic data. As Dr. Odenike has pointed out before, the anemia is the one that continues to be persistent and then also weighted as you get into the deeper scoring systems. But now, more recently, there is the MIPS scoring. So the molecular IPSS, MIP70 version 2.0. So in all truthfulness, we are using that in the clinic. There's a convenient online calculator. It takes into account for the very first time fibrosis, which is really great to see, CALR or not, high-risk molecular mutations, in addition to the clinical factors. So I would say, yes, use a prognostic scoring system, use one that's reliable, use one that can be used at either diagnosis or later on. And then once you use that, determine stem cell transplant eligible or not. If you can refer to a transplant eligible center, go for it. And then if the patient is intermediate to high risk disease, I always prefer a clinical trial if it's available. And if not, then JAK inhibitor standard therapy.